Welcome to Stockholm, Sweden. I'm at the Center of Innovation at Karolinska University Hospital in Stockholm. I'm a rheumatologist. My name is Sofia Ernestam. As a rheumatologist, patients ask me, how was my blood count? That is one of the most common questions that I get. And we know that more than 60% of patients are very interested in their blood sample results. In chronic diseases such as arthritis, blood sample controls are frequent during often lifelong treatments with different drugs. It is part of the important patient safety work. These blood sample referrals are often done many months or years in advance. And patients are of course very curious about the results. They call the outpatient clinic, they ask the nurses, they wait in long telephone queues, curious to have the result. Or even more often, they worry about the result, about having a low blood count and being forgotten by nurses and doctors. And they worry all days at home, on their way to the consultation, in the car, in the waiting room, and also in the consultation room. They worry before the physician has told them about the results. And they ask, if I have forgotten to tell them, how was my values? How was my blood count? On the other hand, sometimes patients forget to take their blood samples, and quite often the wrong prepared referral were taken by lab assistants among the sometimes many referrals you could choose between. We decided to give patients the power of governing their own blood sample handling process. So we built a generic technical solution for this process. Patients were invited to be responsible of handling this process themselves. They log in secure web page on the national patient web page and order a predefined blood sample referral. And here they choose the right predefined referral and receive a receipt, and then they can find easily their way to the closest lab. The lab assistant finds the lab referral in the system, and now it's time for the blood sample. The result is ready, and the patient receives an SMS when it's ready and can log in again to read the result. At the same time, and this is very important, in the patient safety work, the healthcare provider, the nurse or the doctor, get the result in the EMR. So at the same time, 4 eyes can see the result instead of in the normal way, 2 eyes. And at the consultation, we both results before. There is no worry at home for the patients. There is no worry in the waiting room. And we can start the meeting, the consultation, talking about the issues that patients want to discuss. So what are the main worries from the health professionals? The most common questions I get from health professionals is, don't patients take blood samples tests too often when they have the freedom to choose themselves? And we have had no problem in the pilot project about this. Patients, they learn about the blood results and they don't want to get this blood samples test more often than needed. So there is no one who wants to give blood more often than actually needed. And also another question is, may patient take as many blood sample tests as they want? Yes, of course they can, and we can also have some kind of, we can allow them to take just 4 tests in a month, for example. Another question has been if patients really can handle this themselves. And yes, most patients can do this, but we always discuss with the patient before if they are ready to handle this and take the responsibility. Another question is, don't patients get very worried about having the results? Well, they're worried already, and in this way they get worried much less than in the older variant of process. And as a bonus, patients get involved in patient safety issues. What about patients and their reflections? One patient told me, I don't have the feeling that I'm forgotten anymore. So patients feel that they are forgotten when they don't get the results. I think that is so important when we have the new processes for a patient with chronic disease, that they shouldn't feel that they are forgotten. They also feel that they are connected and understand the system. So they don't worry about this anymore. And they're an active part of the healthcare process. It also gives them more knowledge about the disease, their body, and the treatment. And one patient said, I'm just waiting to have more services included and for more diseases. I, as a rheumatologist, is also convinced. I'm also waiting for more services that can connect patients to healthcare. And I'm sure that connecting services will totally change the way we provide healthcare and changing patients' daily life. Thank you.
Hi, my name is Helene Skogsberg. I'm a nurse, and I also work as a project leader here in an innovation center. Today I'm going to talk about heart failure patients and the creation of the fast track for those patients. Heart failure is a chronic disease that a large group of people are suffering by. Many of the people that have heart failure have frequently hospital visits. In fact, it's the most common reason why people over 65 years admitted to the hospital. The readmission is high, and there are also the costs. They are also high for this group. The 5 years mortality is 50%. Our problem at Karolinska was that we had a lack of beds in the heart ward. So the heart failure patients are spread all over the hospital in different wards and different clinics and themes. It's not always they get the right guidelines, treatment, or the best treatment provided for them. So we also saw that we had a lack of communication between the different kind of wards and even outside the hospital. So the idea about this fast track is to coordinate the care and to communicate between patients, between wards and other caregivers. We want to be a bridge between patient care, outdoor care and primary care. Patient can come directly from ER up to this fast track instead of being admitted into indoor patient care. And after discharge, they can also come directly from the ward or a few days later. In this way, we avoid unnecessary admissions. Patients and relatives are always welcome to have a call. If they have questions, if they feel insecure, if they need a quick appointment for treatment during the day. But we have also seen that even for other caregivers, it's very important to have this straight connection, to be able to come in contact with the heart failure specialists. This we have seen been very important. In those 10 months that we tried this, we had over 2,000 visits and phone calls, but about 199 unique patients. And each patient reduced 14 in-day patients day a year. That gives us 1,200 days less than before. The readmission was from the beginning 59%, and it was very fast. These patients, they come in for 3 or 6 days after they have been admitted from the hospital. For the fast track, we have seen for the patients that we have reduced that readmission to 10%. And I wonder if we scale and more get more unique patients in this track, and if we start to work and develop the way of working and methods and processes, is it possible for us even to get any lower in those numbers? This fast track that I'm talking about is provided at a clinic, which also have been a test bed from the Innovation Center, where we can try to work and try new ways of working. This is one example. Here we have a patient that can be, by a video call the clinic, can measure the weight, they can measure the blood pressure at home, and then they can discuss and have a face-to-face interaction instead of coming to a visit. We have also tried to have some video conference and video runs with other caregivers like primary care and ASIH, who is the advanced care at home. And this is very successful. We increase competence and guidelines and treatments are higher for these patients that we can discuss in these rounds. Other solution can be that we collaborate with, for example, e-health to try new ways of working. So what we have done during these months is that we have reduced readmissions. We have reduced the numbers of beds for this group of patients. We have relieved the ER. But more important, we have also been able to have more available care for the heart failure patients. And that gives us a quite quality for those. And here I leave you with one of our patients.
On the 12th of June in 2003, I was diagnosed with Parkinson's disease. My daughter was 4 months old and I was 32. And to learn that the symptoms I had been experiencing for a very long time were caused by Parkinson's disease, which, as you probably know, is a disease associated very much with people in the 70s or 80s, was a really hard blow. I felt like my life was over. I thought I would never smile again. But my life was far from over. Having a baby that needed me encouraged me to face my problems head on. I started to learn as much as I could about the disease. And I also smiled. I started to learn as much as I could about this strange disease, and I also smiled and laughed a lot. As I learned to live with Parkinson's disease, about all the different symptoms, both motor and non-motor symptoms, learning about different medications, and learning about also the different areas in healthcare where I could get help. There's a lot to learn and plenty of places to look for information and help. There's a lot of navigation that needs to take place. And this is why I, 6 years ago now, decided I wanted to try to give people coming after me the map I didn't have, which is why I started studying at Karolinska Institute in Stockholm, and where I'm now a doctoral student in the area of active self-care for Parkinson's disease. And successfully managing a complex chronic condition is hard work. And like in any job, you need to work with good people. You need to have a good team. And the key player in my team is my neurologist. I see him once or twice a year, about half an hour every time. That is 1 hour per year. The rest of the year's 8,765 hours I spend in self-care. And it's only during this 1 hour of the year that I'm with my neurologist, symbolized in this picture by this one red circle. It's only during that 1 hour that I'm in direct contact with Swedish Neurological Specialty Care with its clinical practices and guidelines. It's only during that 1 hour that my neurologist can observe the symptoms I have and also see what effects the treatments he prescribes are. But it's during all those hours in self-care, all those 8,765 hours with the blue circles in this picture. By the way, there are 8,765 hours of blue circles because I made this picture myself, and I know they're right. I'm that much of a nerdy engineer. But it's during all those hours in self-care that I can observe my symptoms, and also that I can put my treatment into action. Because frankly, my neurologist doesn't even know if I take the medication he prescribes or not. But I do, of course, because if I didn't take my medications, I know I wouldn't be standing here today. I would have a very hard time moving. I would probably not be able to work. I would probably not even be able to take care of myself. And this picture shows my pills for one day. I take 7 different prescription medications, 6 times a day in 4 different combinations. And as the curious engineer I am, I wanted to understand better what effects these medications have on me, and if that effect varied over the course of the day. So a couple of years ago, I was inspired by a doctoral thesis to use finger tapping as a proxy for medication effect in Parkinson's. I found a free app on my smartphone for finger tapping, and for 2 subsequent days, a couple of years ago, I tapped on the screen as fast as I could for 30 seconds with the middle finger of my right and left hands respectively. And I made this graph that shows the results. The bars show my medication intake times, and the lines show the results of the tapping tests. The 2 lower lines show my left hand on these 2 subsequent days, and the upper 2 show my right hand the same 2 days. And by doing this, I learned a number of things. I learned that the effect of my medication does vary over the course of the day, as you can see by this pattern where the lines go up and down a bit. I also learned that my left side is more affected by my Parkinson's, actually both by my Parkinson's and by the medications I take. But the most important thing I learned was this dip that I had in function around lunch that you can see circled with a red circle here. And I didn't know that this dip existed, that I had lower function around lunch until I tried this. And this realization led me to changing the times of this medication from 11:30 to 11. And adding another medication that made this one last longer. That medication I already had from my other doses. And this resulted in me having a more even medication effect throughout the day. And I found these results very interesting, and I wanted to enable others to try to do the same thing for themselves. And to do that, I worked with the Center of Innovation at the Karolinska University Hospital, where we are right now. And they helped me develop this app that we call Parkwell. And Parkwell enables people with Parkinson's to record their medication intake timings. And since the tapping test takes quite a lot of time to do, we used a different measure. We used a simple score of 1 to 5 of what we call feel well time. And what people did was, the idea is that people just record when they take the medications with these drop-down menus here. And then also record how they feel when they do this, if they feel excellent, good, average, bad, or terrible, as you can see on this screen. And the idea is then that it produces one of these graphs that you can see as well with the medication intake times and the results of the feel well time as the line, to be able then to see how you're doing over the course of the day, see if you can see any patterns. And we hope to be able to allow other people with Parkinson's to use this for a week or so before they visit to their neurologist, and that this will prove valuable as a source for data for shared decision making. And I also, on a more personal note, I hope and plan to complete my doctoral studies within a year from now. And I can honestly say that even though there is a lot of work still to be done, I can say that I at least started developing the map I would have wanted to have when I was diagnosed. I've started the map, but there's still a lot of uncharted territory in Parkinson's, but also for a lot of other diseases. Let's work together to make the world a better place for people with chronic diseases. Thank you. What's next step, Elian?
I think very important is to see the needs, to really talk to patients, to relatives, and to see what are the needs right now. And as you have done, lots of people have lots of good ideas on what should be good and what we could do better.
So what do you see as the biggest hurdle for not doing that today?
That's a tricky one. I would say that more focus on to talk and to structure, actually ask around and have studies and try to see what the needs are.
Okay, yeah.
More structured, I would say, than we do today. Yeah.
Okay. Sophia, you've done some really impressive work with this patient's own blood samples. So where do you see what's the next step? What's left to be done in this area?
For me, it's important to actually develop more services that connect patients to healthcare, and also for patients to be able to show the self-care they do to the providers and to the nurses and doctors. So I would say more e-services that actually connect, and also that you have a whole picture of e-health services. So they're not just one service, but they are all connected together. So, and I think that will also drive, together with what you said, just to try to listen to patients, what are the actually needs, because I think we can't just guess. We really need to develop together with the patient all the time and in an iterative way. So, and to do more of these services, and also understand when I actually need to have a physical meeting, and that will also change, I think. So for me, it's more of the connectivity. Yeah.
Where do you think we are in 10 years from now in this area?
Oh, hopefully we are a long way from this. There's possible to be at home more and to do things, try things for themselves at home, and more technical support and more that we have staff that's comfortable with using these things. Because we saw in this study we had with the heart failure patients that we have a questionnaire for the patients, and we leave even the same questionnaire for staff, and we get so different kind of answers. The staff did think that the patients with heart failure in this case were so old, they were not interested about technical supports or whatever. But the patients, they were very positive about those things. So therefore, I think it's very, my experience is that it's the staff that we have to work with a lot to accept.
Change attitudes.
Yeah, absolutely.
Because I hear often, I'm sure you can imagine that I'm often told that, well, Sarah, not everybody's engaged in powerless use, and not everybody can do what you're doing. But then I always say, well, I wasn't as engaged as this seven or 8 years ago either. So it doesn't have to be a constant. And I think everybody can do something, but everybody doesn't have to do everything. What's your view on that, Sophia? Have you seen similar examples in your area?
Yeah, I think we need to have also to show the good things for the staff, that actually their work will be, they will do more of the coaching part, and some of the, for example, for this blood sample, then you can actually, patients can do it themselves. So staff can do different things. So you actually need to address these positive things.
Yeah.
So I just wanted to ask you, Sarah, what are your ambitions for like 5 years on?
Oh, yeah. I hope to be able to continue building this map and trying to sort of explore more of the uncharted territories. But I also hope to be able to contribute to changing healthcare into a new kind of model. So I see that healthcare needs to go from providing healthcare, from delivering healthcare, to supporting self-care. And that, I think, will take a lot of policy work and legislation and not least reimbursement systems. So that's what I see is needed, both in Sweden, but also from what I've seen from other parts of the world. But as you said, both of you, it will take a lot of attitude changes in the profession, I think, more than in the patient communities. Because the patients, I think, in a way, Google and Airbnb and Uber and these companies that have disrupted other areas, they have sort of spoiled us citizens in a way. So we expect more than healthcare can provide in these days. So what's your view from the professional side on that?
Yeah. I think also you should think of, it's not like a flip like that. No. It will be small steps, but all work very methodological in a very strategic way. Yeah. I think we can then we can reach it, but it will never be like, okay, here we have all these EHS services.
Use them.
Please start. No, but you will start using them for, well, the first doctors, of course, and then you will go on and say, oh, it's good for them, and then maybe for the patients that have language barriers, I think eHealth will be really a great tool for us to work with.
Both for patients and providers, I think.
Yeah.
Mm-hmm.
And I think the most important is that we try. And some things are not going to be so good, and some things are going to be bad. I was thinking about the thing that you talked about, that one of the questions was, well, are the patient going to take lots of blood samples now or not? So you just have to try it, and then you can see, was that a problem? Well, then we can work around that problem later on, but we have to try to get further.
I think that's a misconception as well as what you said about older people, that healthcare and the system thinks that we patients want more healthcare. Well, we don't. We don't want to be in healthcare. We want to spend our life doing things we enjoy rather than being in healthcare. So we want to have healthcare in a way that we can have a better life rather than spending all our lives in hospital. So it's not really, but that's a challenge as well. These attitudes that needs to be shifted.
So that was very important to just try, and then we can see that it was just an attitude and not a problem, really.
Exactly. Yes. So what can we do? What can we say as sort of a common goal? Do you have any last words for the live stream that we can sort of sum this up with?
Well, we have started this journey now, so it's just keep on trying and keep on developing and keep on trying new ways.
Yeah. And try to work together with patients. Exactly. I think actually we can do a lot in the attitude between professionals and patients. And I think starting to work together in workshops and discussions and have the patients going together, that will actually change attitudes and also give much more ideas.
I completely agree with you, and that we need to work in innovative ways all over across the board. And we have to have the courage to try new things, like we do here at the Center for Innovation at Karolinska University Hospital.
So, thank you.
Thank you. Bye from Stockholm.
Bye.
Bye.
Bye.